this will be your discussion on the care of clients with disturbances in locomotion. So here, we'll be discussing first the infection and inflammatory disorders. We will start with osteomyelitis. So class, for osteomyelitis, the key word that you need to remember is that it is an infection of the bone that would result in inflammation, necrosis, and formation of new bone. So the keywords are, this is an inflammation resulting to necrosis, and then there is a formation of a new bone. This is more common among men compared to women, and this is usually related to a higher incidence of blunt or penetrating trauma. So what are the two major types? So you have your acute and then you have your chronic myelitis. Acute, the cutoff here is 4 weeks, and then your chronic is more than 4 weeks. Acute is more common in children, whereas your chronic is more common in adults. There are different risk factors that you need to consider, all of which are enumerated in your handouts. Now, let's talk about the pathophysiology of your osteomyelitis. So look at the risk factors. Okay, so one of the risk factors that you would have is being malnourished or poor nutrition. So poor nutrition, that would mean poor immune system also. Second, you would have your old adults or your elderly. So your old adults and your elderly would also have poor immune system compared to the young adults. The third one is impaired immune system. Then you also have your chronic illnesses, for example, your diabetes mellitus and then your rheumatoid arthritis. For your diabetes mellitus, the role of your diabetes when it comes to the development of your osteomyelitis may be actually twofold. Due to the increased risk of infection, which is brought about by the increased levels of your blood sugar. Other than that, okay, your diabetes mellitus would also damage the microvasculature. Because of the damage to the microvasculature, it results to venous insufficiency. So because of the venous insufficiency, there will be a decrease of blood supply going towards the bone, which aggravates the process of necrosis. Next, you have your rheumatoid arthritis. When I talk about your rheumatoid arthritis is considered to be an autoimmune disease. Okay, as an autoimmune disease, it would have systemic damage, and part of the damage will be also your bones. Next, immunosuppression. So immunosuppression brought about by your steroids. So steroids, especially for your patients who are having asthma and your patients who are having, your patients who are being maintained on autoimmune disorders, who would have your steroids, and your patient who are post-transplant. So this leads to immunosuppression. Okay, another example will be your patient with cancer also. So because of immunosuppression, they would be more susceptible to the presence of infection. And because of that susceptibility, your osteomyelitis would develop. Then you have the use of your surgical site markers. Okay, surgical site markers is supposedly intended to prevent wrong site surgery. So your surgical markers, as the term implies, recall in your peri-op nursing, surgical markers are actually intended to mark the site, especially if we're talking about sites of surgery which are bilateral. What do I mean by that? For example, if you're operating a bone, for example, the femur, notice that you have your left and your right femur. Hence, surgical site marking is crucial according to your standards so that there is no wrong procedure that would be done. However, what happens? There have been studies which shows that because of the surgical site marking, there has been a spread of infection. There has been a spread of infection. That's why the guideline has been updated to say that the surgical site marker that is used for a certain patient must only be used for that patient, and not for other patients already. Added to that, if you would look at your handouts, you can add your chronic illness. So you have your chronic kidney and your chronic liver diseases. So your chronic kidney and chronic liver diseases would also lead to immunosuppression and vascular damage. And because of that, of course, your increased risk for infection. Then we have your alcoholism. Alcohol is known to damage your bones also. Now, there are different ways for this to spread. Or there are different ways for your osteomyelitis to be classified. So one, you have your exogenous, you also have your endogenous osteomyelitis, and you also have your contagious osteomyelitis. When I talk about your exogenous osteomyelitis, exogenous, so the word there is exo, it would mean that the infection is coming outside the body, as in an open fracture. So when I say open fracture, meaning there is a break of the bone, there's a break, in the continuity of the skin, and then it's possible that the fracture which has been broken is already going out of the skin. hence the risk for infection. Then you have your endogenous. So endogenous occurs in organisms that are carried by the bloodstream from other areas of infection in the body. Okay, so for example, if there is presence of infection in another bone, okay, let's say for example your humerus, it is possible that this infection would also travel going towards your femur. Okay, the endogenous spread. Whereas when I say contiguous, okay, it is in which the bone infection results from skin infection of adjacent tissues. So your key word there is adjacent tissues. Okay, so for example, if your osteomyelitis would be on your lower leg, it would be your tibia or fibula that will be infected. So the skin infection is also on the lower leg. Okay, that would mean contiguous spread. Okay, they are just adjacent to one another. If you would look at the textbook would expound that there could be blood-borne spread. Obviously, blood-borne, so that's through the blood. Okay, you have your contiguous or your focus spread, and then you have your vascular insufficiency. So vascular insufficiency, as in the decrease of blood supply going towards a specific area, increasing the risk for necrosis. Now, when I talk about hematogenous osteomyelitis, so it's blood-borne. Again, when I talk about contiguous focus, this would be referring to your bone surgery. Okay, this would be referring to your open fracture and even your traumatic injury. And in vascular insufficiency, so when I say vascular insufficiency, you would have your diabetes mellitus, and then you would also have your peripheral vascular diseases. Okay, so peripheral vascular diseases could cause vasospasms, which would decrease also the flow of blood going towards the extremities. Now, what happens? Staphylococcus aureus is among the most common causes of your osteomyelitis. And because of this, okay, it would lead to inflammation and infection. So we had inflammation first. There will be increase in the vascularity and there will be edema on the site of infection. So what happens? This infection may extend, and the extension of your infection would lead to bone abscess. Okay? Once bone abscess would occur, there will be formation of sequestrum. So your sequestrum is your dead bone tissue. And to that, okay, there will be abscess. Okay? So once the sequestrum and abscess is present, in osteomyelitis, there is a possibility for new bone growth. Okay, that new bone growth is your involucrum. So picture a bone. Okay, for example, this will be your bone. There will be presence of sequestrum and then abscess. So sequestrum are your dead bone tissues along with your abscess. And then later on, there will be new bone growth or your involucrum. So with that, okay, it makes it difficult for your chronic osteomyelitis to be treated because this area again will be covered by new bone growth. That's why the tendency in osteomyelitis is for it to be recurrent. Okay, it has a tendency to be recurrent. Okay, so what are the signs and symptoms for this patient? You would have chills, okay, high fever. You would have pulse, increase in pulse, and malaise. Okay, the area would be painful, the area would be swollen, the area would also be tender. If you would look at the imaging studies, X-ray could be done. Okay, you have your MRI. Okay, your MRI would give a detailed image of that. Okay, your X-ray would just reveal soft tissue edema, and then in chronic cases, it would reveal large irregular cavities, raised perosteum, and then the presence of your sequestra. Okay, that would be in chronic cases. Whereas your radioisotope bone scans and your MRI could possibly help in early diagnosis of your osteomyelitis. Okay, because they will be able to detect that there is a presence of abscess and presence of dead bone tissue. Again, the term for that is your sequestrum. Okay, the same for your CT scan. Now, ESR, erythrocyte sedimentation rate. What do you think will be the value of your ESR? So your ESR here is expected also to be increased because this is an inflammatory problem. How about WBC? So your WBC is also expected to be increased because we're talking about infection. So recall the normal values for this. Okay, that's why your patient would have leukocytosis and then elevated ESR. Okay, your blood culture studies will be positive. Okay, your blood culture is ideal for you to determine actually the type of antibiotic to be used. Okay, blood culture will be positive, especially if we're talking about hematogenous spread or your blood-borne spread. But if we're talking about your contiguous spread, a direct culture to the bone would be an ideal move. So, okay, one of the keystone in prevention of this is your asepsis. This is like a surgical site infection, especially if strict aseptic technique was not done during surgery. What is our medical management? Since we're talking about infection, antibiotics would be very crucial. You need to have hydration, you need to have vitamins, protein, and then a possible correction for anemia. Why would my patient have anemia? Recall that this is an infection and inflammation of the bone. Hence, your bone marrow would be affected. Okay? The area is immobilized. The affected area is immobilized. The purpose of which is to decrease discomfort and to prevent pathologic fracture of your weakened bone. Other than that, you would have your drug therapy. So notice, your antibiotics would even be given for 3 to 6 weeks. So as long as you will have your culture specimens. So what are the antibiotics commonly used? Handouts, you have your penicillin and cephalosporins, which are good for your staphylococcal organisms. So the aim is to control the infection before the blood supply in the area would diminish, leading towards necrosis. Now, antibiotic therapy may be administered orally for up to 3 months. Okay, imagine up to 3 months. Okay, once the infection is controlled. You would have surgery. So debridement need to be done for us to remove the chronic infection who would not respond to antibiotic therapy. There are two procedures. You have your sequestrectomy and then you have your saucerization. So in sequesterectomy, as the term implies, ectomy and then sequester. Okay, so your sequestra, recall, is your dead bone tissue. So your sequestrectomy is the removal of your dead bone tissue. Whereas your saucerization is the removal of the sufficient bone to convert a deep cavity into a shallow saucer. Okay, why? If this will be your osteomyelitis class, for example, it has a tendency to become a deep cavity. So with that deep cavity, there will be an increased risk for infection. So the procedure that will be done will be your saucerization. Okay, so this is a deep cavity. So what the doctor will be doing is to reduce an amount here of the bone, okay, and reduce a part here so that there will be a formation of your saucer. Okay, hence the term is saucerization. Pardon my talent on art for that. Okay, so again, surgical debridement, you have your sequestrectomy, and then you have your saucerization as the procedures done for osteomyelitis. Another way for us to look at the pathophysiology of your osteomyelitis is to look at the one presented in your handouts. So if you look at it, once the bacteria would multiply, okay, in the bone, it would result to the inflammatory and immune responses, leading to pus formation. The formation of pus would result to edema and then vascular congestion. With that, the organisms can be carried through other segments of the bone. Okay, that is done through your Haversian canal. Once it reaches the outer margin of the bone, the tendency for that is the bacteria will be raising the periosteum. So recall that your periosteum is the covering of your bone. Okay, it's the covering of your bone. So because of the presence of the inflammatory process inside related to the infection, the periosteum will be elevated. Okay, and because of this, that would lead to the spread to the cortex, and then later on the disruption of the blood vessels, okay, leading towards necrosis. And then it would separate from the living bone, which would be a good medium for further growth of microorganisms. Okay, so class, if you would look at this, these X-ray images would show the sequestrum. So sequestrum, remember that dead bone tissue that we have, and then this is already your involucrum. So when I talk about the involucrum, it will already be a new bone growth that actually covered your sequestrum, okay, which makes it difficult for us to treat the infection. Okay, that's why imagine 3 to 6 weeks of antibiotics and even up to 3 months of oral antibiotics for your osteomyelitis. And since we're talking about bone, take note of the bone pain that your patient will also experience. Okay, so another illustration of your sequestrum going towards involucrum. So notice the irregularity on the bone growth also, because underneath which, okay, you would have your sequestrum. Okay, so in acute myelitis, here are the possible assessment findings that we can have. There would be fever above 38 degrees Celsius. There could be swelling around the affected site, erythema, redness about the affected area. No need for for you to memorize that, because swelling and erythema is part of inflammation. There will be tenderness. Okay, that's part of inflammation. And then bone pain, which we describe as constant, localized, and pulsating. Since this may involve bone, it would intensify with movement. Okay, so bone pain with or without manifestation is a common concern of a patient with bone infection. Okay, that's common for a patient with bone infection. Chronic. In chronic osteomyelitis, so fever, swelling, and erythema are less common in chronic osteomyelitis. Instead, there will be ulceration. There will be sinus tract formation. There will be localized pain, and then there will be drainage from the affected area. Okay, so that drainage is related to the chronic infection that is occurring already to your patient. Okay, so diagnostic test, just as a recap. So X-ray would reveal the soft tissue edema. Your radioisotope bone scan again and MRI would be for early diagnosis. Then for your ESR and then your WBC, that would be an increase. And then your culture studies would be positive. So take note, it will not only be your blood culture, but your bone culture or tissue culture may be positive, especially if we're talking about your contiguous spread. Okay, so antibiotics, you have it there. That would depend on your culture result. Now, for the supportive measure, hydration is encouraged. Okay, diet high in vitamin and protein, and then correction of anemia. By the way, for the correction of anemia, that would include the administration of your erythropoietin. That would include the worst cases would be your blood transfusion. And then in some cases or milder cases, the administration of iron. Okay, and then the immobilization, we've talked about that earlier. Then, again, the aim of your antibiotic therapy is to control the infection before the blood supply to the area would become diminished, before necrosis would even occur. Okay, recall again the surgical management. We talk about those. And then your post-op care for your patient. So, after the surgery to the patient, our nursing intervention will be focused on increasing the venous return. So the increase of your venous return could be done through elevation of your affected extremity, and this is intended to decrease the swelling. And then your neurovascular status. So recall CMS again. So you have your color, you have your motors, and then you have your sensation. Okay, so assess for pain, warmth, temperature, and distal pulses. If there will be decrease of distal pulses, inform the doctor. If there will be cooling of the extremities, inform the doctor. Okay, because you have the 5 P's as the sign of your neurovascular compromise. Then, we have the following nursing diagnosis for our patient. 1, you have your acute pain related to inflammation and edema. So what do we do? Sprinting could help. Okay, immobilization could possibly decrease the pain experience of your patient. Continue to assess the neurovascular status. Assessment of the neurovascular status will be able to help us determine if there is progression of the infection, if there is impediment already on the functioning of the muscles and the cardiovascular system. And then elevate. Your elevation will be able to address your edema. Next, you have your impaired physical mobility that would be related to pain, use of immobilization devices, and weight-bearing limitations. Then you also have your risk for infection. Okay, risk for infection, especially your bone abscess formation. And then another risk is that for the transfer of infection, of course, to your other bone. So still maintain your strict hand washing. Then we always monitor for hyperthermia for that matter. Then you have your risk for superinfection. Why superinfection? Imagine you'll be using antibiotics systematically for 3 to 6 weeks. Okay, the risk for superinfection related to the death of the normal flora in our body. So you have oral vaginal candidiasis. Okay, you should monitor for that. Monitor for loose or foul-smelling stools. It may be your C. DAD already, C. difficile associated diarrhea. And then, as much as possible, wound suctioning is done to prevent fluid accumulation. And then there could be also deficient knowledge related to the treatment regimen. Compliance to a treatment that would last for 3 months is very difficult for our patient. Hence, they need constant reminder for that. Then, you have your carpal tunnel syndrome. Another problem, carpal tunnel syndrome, your CTS. Your CTS, carpal tunnel syndrome, is known as an entrapment neuropathy. Highlight the word entrapment because what actually happened here is that in the carpal tunnel, okay, our nerves was entrapped. Okay, your median nerve is entrapped. So the median nerve at the wrist is compressed due to the thickened flexor tendon sheath. Now, what causes the thickening of your flexor tendon sheath? It may be typing jobs, okay, it may be constant motion, or it may be inflammatory process due to an abrupt movement. Okay, skeletal encroachment occurs along with edema or a soft tissue mass. Okay, now this is more common among women, secretary jobs, 30 to 60 years of age. Okay, then commonly caused by repetitive hand and wrist movements, as I mentioned, typing. This is also associated with your arthritis, diabetes, tumors, and trauma. So, you might be thinking, how come diabetes mellitus would be leading to carpal tunnel syndrome? So again, that would be because of the decrease on the blood flow related to the damage on the microvasculature that could be brought about by your diabetes. Arthritis. Arthritis, of course, will be damaging your joint, resulting towards the inflammation of your joint. And then there are specific types of arthritis that would result to nodules. And these nodules could also compress on your median nerve. Okay, because again, recall that you have your median nerve as your main problem. Okay, so what are the assessment findings for this patient? So you have your pain, numbness, paresthesia, weakness, and then your Tinel sign. So pain. Pain is the crucial sign in your carpal tunnel syndrome. Okay, again, related to compression of your median nerve. Numbness is because of the compression of the nerve, okay, that would result to numbness on your fingers. So as your paresthesia. Now, there could be weakness. So your patient is unable to move or unable to have the usual range of motion of your fingers. You will have your Tinel sign to be positive. So recall in my discussion and assessment, we've talked about the Fallon sign. Now you have your Tinel sign, which is also classic in your carpal tunnel syndrome. So when I talk about Tinel sign, okay, the tapping here, okay, the light percussion or tapping over the median nerve, which is now considered to be irritated in your carpal tunnel syndrome, at the flexor retinaculum, so flexor retinaculum is the muscle here, would elicit a tingling sensation, described as pins and needles, in the area wherein the nerve is innervating. That would include your fingers and your palms here. Okay, so that's your Tinel sign. So recall your Fallon sign, the one wherein the posterior portion of your palm is faced against one another. If there is presence of pain, that would signal your carpal tunnel syndrome. Treatment. So what do we do? There will be your intra-articular injection of corticosteroids. Okay, intra-articular injection of corticosteroids. So one, you have your methylprednisolone. Okay, so that's one. The purpose, when I say intra-articular, articular there refers to your joints. So intra, that would be between your joints. This is done by the doctor. Okay, wherein a direct injection of your steroids is done. And then you have your oral corticosteroids, an example of which is your prednisone. And then you have your application of wrist splints. A basic principle in the management of your orthopedic and your musculoskeletal problems is your rest. Remember, you'll have your RICE, no? Rest, ice, compression, and elevation. Now, for this one, wrist splints, that's the principle of rest. So, for us, for the inflammation to decrease, you need to rest that area which is being affected. So, notice that you'll have patients who would have wrist splints for several days, okay, until the inflammation will be gone. Because continuous usage of that area that is affected, okay, would lead to further damage and then further pain experience. Then, surgical management. For the surgical management, you would have the traditional open nerve release. Okay, so then you also have your laser surgery. Usually in the present setting, you would observe the traditional open nerve release. So both of these are performed actually under local anesthesia. So no need for your patient to be on NPO. After the procedure, your patient would wear a hand splint, and they would advise to limit the use of your hand during your healing. So the patient may need assistance with care and ADLs. And then recovery may take several months or several weeks or months. Okay, that will be part of your education for them not to expect again to be recovering right away. Okay, that will be the end of the discussion on your infectious and inflammatory disorders. Okay, but not the end yet of your musculoskeletal diseases. The next topic will be focused on metabolic bone disorders. Thank you for the kind attention.